So I'll give you a very short overview of the use of angiogenic factors in preeclampsia, but also the evolution of how we have changed our concept of preeclampsia, which, as you know, essentially the main notion in most guidelines is that you have to remember that preeclampsia is always a potentially severe disease, and therefore, because we don't have treatment, we have never to forget that the objective is to protect the mother to the best possible outcome. And this seems obvious, but it's very important becoming in many centers in the world, because we are seeing less and less preeclampsias because of the screening of the first trimester and the aspirin. So I will summarize which have been the recent changes in the diagnostic criteria and how can we individualize management, and of course in both of these parts angiogenic factors have come as a very important aid and a very important biomarker of preeclampsia. So concerning the diagnostic criteria for preeclampsia, the very point that I want to make is that for 100 years the diagnosis of preeclampsia has been made by the combination of hypertension and proteinuria in the blood. This was discovered at the end of 19th century, and the diagnosis of preeclampsia has been made for more than 100 years based on hypertension and protein, which is not bad, but it can be improved. And traditionally, we have been taught that when there is hypertension, in a pregnant woman, then once hypertension is after 20 weeks, we need to look for proteinuria, and then if there is proteinuria, there is preeclampsia, and if there is no proteinuria, there is gestational hypertension. This has been the classical criteria, but most guidelines are changing them with two very important things. Okay? So the current concept is that preeclampsia is hypertension with any sign of placental endothelial disease. And in future years, we are going to move to a moment where you will not even need hypertension. So that's very important to remember. Preeclampsia is a disease of the marginal endothelium that in the end, it always has hypertension, but not always in the beginning. And that's why it's important to remember. So it is indeed a hypertensive disease, but not only a hypertensive disease. Preeclampsia is hypertension without any sign of placental endothelial disease in principle. And any sign of placental endothelial disease is present in two ways. The first is the presence of target organ damage. Of course, you have proteinuria, the classical sign, but any other sign which you might find in combination, it has been considered preeclampsia. Even if you have an abnormal uterine artery with hypertension. And this is one point that is very inclusive. The other very important one is angiogenic factors. Okay? Angiogenic factors are a molecular diagnosis of preeclampsia, and in the end, it will be the only way of diagnosing preeclampsia. So today, I am talking to you about this combination. In 5-10 years, we will be only talking about angiogenic factors. A very short introduction, probably most of you know very well, but angiogenic factors, we call them placental. In reality, most of the angiogenic factors are produced in the endothelium of the mother. Okay? And we have several angiogenic factors in the blood. There are many diseases where angiogenic factors are important, but in pregnancy, we have two main angiogenic factors: the anti-angiogenic split and the pro-angiogenic placental growth factor. The placental growth factor is the same as vascular endothelial growth factor, VEGF, which these factors are very important in cancer. And when you have cancer, you want to suppress angiogenesis. When you have pregnancy, you want angiogenesis because you want the placenta to grow and you want the mother to lower the blood pressure. Okay? So in a normal pregnancy, you have normal placenta, and normal pregnancy is a state of low maternal resistance and low pressure. You need to increase by 2 or 3 liters the plasmatic volume of the mother, and because you need to protect the heart, you need to lower the blood pressure. And that's the physiology. And angiogenic factors are very important for the placental growth and also for the protection of the maternal vascular system. So in a normal pregnancy, you have high placental growth factor and a low antagonist, soluble fluid. When we have preeclampsia, we have the other situation. There is ischemic placenta, there is high maternal resistance, high pressure, the soluble fluid gets higher, and the placental growth factor gets lower. And this is very important because this translates that when we use a ratio between these two factors, it changes. It's normally low in a normal pregnancy, it's high in preeclampsia. And it is very, very specific of preeclampsia. So as I say, now I am going to mention that we combine angiogenic factors. In a few years, angiogenic factors will be the only diagnosis of preeclampsia. But today, we still use a combination. So how do we do that? The first clinical scenario is the classical. We have a woman with high blood pressure, and we want to know if it is gestational hypertension or if it is preeclampsia. Okay? So we combine if there is any sign of target organ damage, or if there is a high ratio of angiogenic factors. Okay? With any of these two, you say, okay, this is preeclampsia. Okay? Most commonly, we use the ratio of soluble fluid with the placental growth factor, and the very accepted number in the literature is 38. Okay? You can also use placental growth factor alone, and normally you use 100. Okay? I don't think there is a need to know these numbers by heart, because normally when you have a kid in your hospital, they tell you, okay, this is too high, this is too low, and that's it. So you have angiogenic factors high, this is preeclampsia, even if all this is negative. Even if you have no target organ damage, if you have high angiogenic factors and hypertension, you have preeclampsia. How you make the diagnosis of superimposed preeclampsia? Okay, we have an existing chronic hypertension. How do I know that this patient is developing preeclampsia? The suspicion is made when there is a worsening of the hypertension more than 20%. Okay, there is more than 20% increase. Okay, is this a real preeclampsia or is it just worsening of her hypertension? So again, we use the same. Target organ damage and antigen is the same. It's exactly the same. Okay, so you integrate angiogenic factors as one of the parameters. Okay? There are many places in the world where angiogenic factors are not routinely used yet. But this is something that you need to incorporate, those of you who still don't use angiogenic factors. They are not so expensive, and they save a lot of days of admission to women, and they save a lot of uncertainty. You have a patient with hypertension, and then the hypertension is at 32 weeks of gestation, and hypertension is going higher. Everybody is getting nervous. And you get this woman into the hospital. Classically, you do blood tests every 2 days, every 3 days. The woman is 160, 110. Everybody is nervous. The woman is more nervous, and then she gets more hypertensive. Okay? And we, in the past, we didn't have any other way. Today, you do angiogenic factors. Angiogenic factors are normal, and you can say this woman, you don't have preeclampsia. This is just hypertension. Just raise a little bit the medication and go home. And we'll see you in 1 week. So it's really a very reassuring way of monitoring this woman. And finally, there is a newer scenario that has come across, which is the diagnosis of uncertain preeclampsia. Okay? When do we consider that we have uncertain preeclampsia? When we have no hypertension, but we think that something is abnormal. Okay? this woman has 2 or more signs of proteinuria or low platelets or transaminases. Okay. You know that this woman had preeclampsia in her previous pregnancy, or she has a disease and we are following her because she has a nephropathy, for instance, and she had proteinuria before pregnancy, and now the proteinuria is going up. Is this a preeclampsia, yes or no? So you combine it and you do androgenic factors again. And in this case, because there is no hypertension, we use a higher cutoff. We don't use 38, we use 85. If it's less than 34 weeks, and if it's more than 34 weeks, we use 110. Right? So this is extremely useful in situations that are not very common, but they are happening in maternal fetal hospitals. I'm going to focus a little bit more in this situation because this has been really a change that is contemplated in many guidelines now. Okay? So this is the same that I'm talking. I have a patient that has no hypertension, but I have signs that are not normal. This woman has proteinuria. She has higher transaminases. Okay? She comes to the hospital because she has stomach pain, okay, stomach ache, and then they do blood tests and the transaminases are higher, and there is proteinuria. They say, oh, what is that? But there is no hypertension. So this is uncertain preeclampsia, okay? The other typical condition is nephropathy or lupus, diseases that the woman has before pregnancy, during pregnancy, and it is very difficult to know if she has or not preeclampsia. In these cases, then you do androgenic factors. And then you can have different results. You do the ratio of soluble fluid to placental growth factor. If the ratio is less than 38, for sure there is no preeclampsia. If it's more than 85, for sure there is preeclampsia. If it's in the middle, it's uncertain. You can do the same with placental growth factor, and then you use 100, you don't have uncertain results. In most hospitals, we use the ratio of soluble fluid to placental growth factor. So before I have told you, for the diagnosis of preeclampsia, we use 34, okay? But now there is uncertain preeclampsia, and we don't have hypertension, so you use a very high cutoff. If it's less than 38, you say, okay, no preeclampsia. If it's more than 85, okay, and then in the middle is uncertain. What do I do with these results? If I have a positive, then for sure this is a preeclampsia. You have to manage like a preeclampsia. Oh, but there is no hypertension. This is preeclampsia. Okay? It's a very important change in our concepts. This is negative. Okay, don't worry. You don't have preeclampsia. If the problem persists, we will repeat in 1 week. If the problem goes away, that's it, we forget. If the result is in the middle, we will repeat in 1 week. Okay? That is the recommendation of most guidelines today. So, as you can see, we don't have hypertension, but we can say that there is preeclampsia. Okay? So the androgenic factors are becoming like troponins for myocardial infarction. You have high troponins, the cardiologist says you have an infarction. And you say, oh, but I have no pain. And they say, yeah, good for you, but you have an infarction. Okay? So you have high androgenic factors, you have preeclampsia. So that's the concept, all right? The diagnosis of preeclampsia has to be made with the philosophy that we have to detect as many cases as possible because we want to prevent the complications. So hypertension is important, but it's not mandatory anymore. Okay? The important thing is to have target organ and androgenic factors. In many cases, of course, you will have hypertension, of course, but just remember that the concept of preeclampsia is getting more like an endothelial syndrome. Okay? Okay, the second part, individualized management. The previous speaker had the time here, I don't have the time. but I think I still have some minutes. So how do we, the concept of individualized management, where we use androgenic factors, but not only, but we are using them, okay? Once you have preeclampsia, your first objective is to know if this is a severe preeclampsia. The only thing that you want to know in a pregnant woman with hypertension or with suspicion of preeclampsia is if I have severe preeclampsia. If I know for sure that there is not going to be severe preeclampsia, I can say, okay, don't worry, no problem. All complications are going to happen in severe preeclampsia. So I want to classify that. I have the severity criteria for preeclampsia that are in many guidelines. Okay, I don't know what this means. I don't know if it's for me. 5 minutes? 5 more minutes. Okay, that's good. I guess it was like that, but I wanted to make sure. Some of these criteria are just that you know that you have to deliver if there is a progression, and some criteria are not so common. It's very uncommon to find pulmonary edema, okay? But if I find it is not only severe preeclampsia, I have to deliver, okay? But these are severity criteria, and this has not changed, okay? But in the end, as I said, when you have hypertension in pregnancy, you are concerned and you end up with 3 main scenarios. You either have gestational hypertension, you either have non-severe preeclampsia, or you have severe preeclampsia, and your concern is severe preeclampsia. But then when we bring that into the way of delivering this woman, you deliver preeclampsia always by a balance of risks between the baby and the mother. If you ask the mother body, the mother body would always say, deliver, I don't want risks. Why do we wait? We wait for the baby. For the mother, the best thing is to finish pregnancy as soon as possible, okay? But sometimes the baby is preterm, so we want to wait. The general concepts are, when you have gestational hypertension, you deliver between 37 and 40. When you have non-severe preeclampsia, 34 and 37. And severe preeclampsia, 34 maximum, anytime if there is a serious complication. This is as long as you are in an optimal setting, of course. If you are in a suboptimal setting and you don't have resources, you change this criteria. So I'm going to talk about optimal setting, okay? So for gestational hypertension, if we don't have any risk factors, okay, let's wait until 40 weeks because the results are going to be okay. But sometimes we have risk factors, and that's why you have to individualize. If the age is more than 35, more than 40 years, if the mother is obese, she's nullipara, she has a past history of problems, if the bishop is very unfavorable or very favorable, or if you are working in a suboptimal setting, don't take risks. Deliver soon after 37 weeks. If you are in a good setting, there are no risk factors, you can wait because these women have normal outcomes. Okay? What happens when I have non-severe preeclampsia and there are no risk factors? Well, it's safe to wait until 37 weeks. But you have to keep an eye because some of these women complicate. And the best thing is to try to advance yourself. And how do we do that? We do that with history. If this woman had a previous severe preeclampsia, be careful. You have to deliver at 34, not at 37. If you are in a suboptimal setting, of course, and if you have androgenic factors above 110, there are several studies that have demonstrated that you have to deliver at 34 because this woman is going to complicate. I have a patient at 34 weeks, everything looks normal. And I measure the ratio, and the ratio is 200. Deliver. Don't wait. This woman is going to develop severe preeclampsia in more than 50% of the cases. Okay? The ratio is low. Good. Let's wait. Okay? And then for severe preeclampsia, again, if there are no risk factors and I am in a very good hospital, I can wait until 34. In some countries that could be 32. Okay, you have to look at the national guidelines. I don't know what the national guidelines in Vietnam say. It is between 32 and 34. Okay, generally in Europe we wait until 34. Everything is perfect. Okay, but if there are risk factors, we deliver at 32. Which are the risk factors? One, history, of course. She had a serious preeclampsia, 30 weeks in the past pregnancy. Okay, we will not wait more than 32 in this pregnancy. Okay, she has a Peers more than 5. What is the Peers? The Peers is the risk assessment. You can do it in the internet. You write in Google Peers preeclampsia calculator. You write if it's chest pain, saturation, platelets, creatinine, and it gives you the risk. If the peer gives you a risk of more than 5%, don't wait more than 32 weeks. Okay? And finally, angiogenic factors. If you have angiogenic factors and they are more than 655, this woman is going to deteriorate soon. So don't wait more than 32 weeks. Okay? When you have angiogenic factors more than 655, the risk of a severe complication, yeah, I guess this means that they should shut up, but I will finish in 1 or 2 minutes. Then you should finish. And then, of course, when you have a very serious maternal complication, you deliver at any time, of course, if there is demand. Okay? So that's a summary. So we have gone from a system where we deliver at 40, at 37, or at 34 for this to a much more refined way. And your main question is what is the risk in this woman with gestational hypertension? If I have non-severe preeclampsia, what is the risk of severe preeclampsia? And if I already have severe preeclampsia, what is the risk of serious complication? And you know that depending on how is your risk, you decide to deliver earlier or later within this gestational age, and you combine 3 things. For very severe preeclampsia, the peers. For non-severe preeclampsia, the angiogenic factors and the risk factors, and for gestational, just the risk factors. Okay? This is the summary. Okay? So try to refine the level, and the key points of my presentation is for diagnosis, you have to aim at maximal detection, use a very wide definition, target organ, proteinuria is one criterion, but not the only one. You can have preeclampsia without hypertension, and try to incorporate angiogenic factors into your practice if you are not using them already. And the second is that for delivery, you have to individualize, you have ranges, and you come later or earlier, depending on the risk, angiogenic factors, your setting, and this is a much more personalized way, and as you can see, the angiogenic factors are an essential way for the diagnosis and management of preeclampsia. Thank you very much.
I'm so sorry.